Good evening, good afternoon from the World Kidney Academy, wherever you are. Welcome to our update in primary and secondary glomerular disease webinar. And my job is to talk about what's new in membranous nephropathy and IgA nephropathy, and hope to take you through some of the critical facts and newer evidence that we are now looking at in these diseases. So, with this background of membranous nephropathy, let's look at what we have learned lately from genome-wide association studies. So, there's a susceptibility loci identified now within PLA2R and HLA DQA1 genes in Caucasian cohorts, and individuals who are homozygous at both loci actually carry 80-fold increased risk of developing membranous nephropathy. In terms of environmental and lifestyle factors, a large multicentric study from China has demonstrated the association of fine particulate matter so that every increase in fine particulate matter 2.5 by around 10 milligrams per cubic meter increased the risk of development of membranous by 14%. The NEL1 antibody-mediated membranous nephropathy has now also been known to be associated with the use of medications containing lipoic acid and complementary and alternative, mainly herbal medicines and mercury-containing skin lightening creams, as demonstrated from recent reports by Narayan and colleagues. In terms of classification, membranous is now classified as either PLA2R positive or negative, and the prevalence of PLA2R is now known to be between 53 to 82%. Thrombospondin 7A, discovered in 2014, accounts for 15% of all membranous and usually has either a primary association or malignancy-associated membranous nephropathy association. NEL1 is now becoming the second most common antigen after PLA2R, but others like semaphorin 3B in pediatric membranous nephropathy have been reported. HTRA1 has been demonstrated in elderly membranous nephropathy. PCSK6 association has now been reported with NSAID-induced membranous nephropathy, and emerging evidence suggests that we really have complement activation in membranous primarily by the classical pathway. So this table kind of summarizes some of the common antigens and the associations with PLA2R, mostly common between 35 to 60 years, and thrombospondin at a later age of onset 50 to 60. But then the others are in different areas, but semaphorin 3B is primarily at a younger age. When we look at the incidence, PLA2R is obviously 70 to 80%, but now NEL1 is 6% to 21% of PLA2R negative membranous nephropathy now. When you look at the circulating antibodies associated with this, predominantly IgG4 is what's reported with PLA2R and thrombospondin 7SA, as well as with HTRA1 and contactin 1. But when we're looking at commercial availability, it's only there for PLA2R in the form of ELISA or indirect immunofluorescence, and also with thrombospondin 7SA. When we have suspected membranous nephropathy, one can order PLAR immunofluorescence testing, and if it is positive, one can do an ELISA, and if the ELISA shows greater than 2 RU per ml titer, one can diagnose membranous nephropathy and avoid a renal biopsy. But if the ELISA is negative or less than 2, then one would obviously need to perform a renal biopsy when there's an indication and take it from there in terms of staining for PLA2R antigen and thrombospondin 7SA. The treatment strategy is around a two-pillar strategy with non-immunosuppressive supportive care, which is the initial and ongoing management that is there for all patients. Immunosuppression is reserved for those with disease progression or with life-threatening complications. Risk stratification is extremely important, and these may be based on the clinical profile, whether you have proteinuria greater than 8 grams per day or kidney dysfunction, which is obviously higher risk, and subnephrotic proteinuria, usually with preserved renal function, has a benign course. One study showed an annual decline in kidney function of around 0.93 ml per minute per year in those who maintained subnephrotic proteinuria versus minus 3.5 ml per minute per year in those progressing to nephrotic range. The serum and urinary biomarkers, high anti-PLA2R titers, are associated with lower spontaneous remission rates. And in one study, there was only 4% remission in the highest tertile, greater than 610 Ru per ml, compared to 38% in the lowest, which was less than 175 Ru per ml. And KDIGO suggests that greater than 50 Ru per ml should be taken as high risk categories. Histologically, chronic changes like glomerulosclerosis, tubular atrophy, and interstitial fibrosis indicate a higher risk of poor outcomes. KDIGO guidelines, we are aware, classify the risk into low, medium, high, and very high, and we'll look at that subsequently in one of our slides. For supportive care, we understand it's all about dietary salt restriction, smoking cessation, weight management, RAS or ARBs, blockade as primary antiproteinuric agents. SGLT2 inhibitors with DAPA-CKD have not provided any definite evidence of benefits, although there's some proteinuria reduction in membranous. Diuretics are needed for your edema, and lipid-lowering agents and anticoagulations when the albumin is less than 2 to 2.5. Primarily, KDIGO recommends low molecular weight heparin or warfarin because of the NOACs not having very certain pharmacokinetics in nephrotic syndrome. In NEL1 related membranous nephropathy, if particularly linked to complementary alternate medicine and skin lightening creams, just discontinuation should relieve the condition in about 50% of the cases. What about persistent nephrotic syndrome, declining kidney function, or high-risk features? Alkylating agents and corticosteroids from the time of Ponticelli, cyclophosphamide, chlorambucil, and prednisone were effective in inducing complete remission in 24 of 42 and partial remission 10 of 42 in one RCT, and safety concerns are now pushing these out of favor. However, they still have room, as we will see. Calcineurin inhibitors like cyclosporin and tacrolimus have shown multiple trials with superior remission rates compared to supportive care or steroids alone at 12 and 24 months. However, relapse upon withdrawal is common, and long-term nephrotoxicity is a risk. One study compared tacrolimus and corticosteroids to cyclophosphamide and corticosteroid and found comparable remission rates at 12 months, but poorer sustained remission with tacrolimus at 2 and 6-year follow-ups. Rituximab as an anti-B cell therapy, observational studies have shown efficacy in treatment-naive, relapsing, and resistant membranous. When in GEMRITEX trial, no difference in primary outcomes at 6 months comparing rituximab versus supportive care, but a higher clinical remission rate at extended follow-up, 66% versus 34%. In the MENTOR trial, when rituximab was compared with cyclosporin for 12 months, at 12 months, rituximab was non-inferior to cyclosporin and superior at 24 months at maintaining remission of proteinuria. However, there were more side effects in the cyclosporin group. In the RICYCLO study, which compares rituximab to cyclophosphamide and steroids, and concluded that rituximab was comparable to cyclical therapy at 12 months, with sustained effects observed until month 36. Up to 40% of patients on rituximab do not achieve remission after 2 years, and efficacy may be particularly low in those with very high anti-PLA2R titers, particularly above 172. So the KDIGO risk stratification we're all familiar with: low risk, moderate risk, high risk, and very high risk, all the way from less than 3.5 grams per gram proteinuria initially to more than 3.5 grams per gram to more than 8 grams per gram, or to life-threatening nephrotic syndromes, and with the associated hypoalbuminemia and risk of thromboembolic phenomena. One can just wait and see for the low-risk category, and either wait and see and hope for some response or spontaneous remission, or start rituximab or CNI plus steroids. And when you go to the higher risk, if your renal function is normal, use rituximab or cyclophosphamide plus corticosteroids if renal function is abnormal, or CNIs plus rituximab is one other possibility. And with very high risk, cyclophosphamide plus glucocorticoids are recommended. In terms of emerging therapies, obinutuzumab is a more potent anti-CD20 antibody, and even in rituximab-resistant cases, one report reported 85% complete remission or partial remission in 59 patients. In another study, 20 of 21 patients treated with obinutuzumab achieved remission compared with 28 of 42 treated with rituximab, with the former acquiring more complete remission, 38% versus 14%. Sequential therapy, one study looked at cyclosporin for 6 months along with 2 doses of rituximab, day 0 and 6 months, and reported a remission rate of 92% at 6 months with a complete remission rate of 54%, and the remission rates were higher than those historically treated with rituximab alone. The sequential treatment with tacrolimus and rituximab versus alternating steroids and cyclophosphamide, the Starman trial, was an open-label study which had 86 patients with primary membranous with evaluated sequential therapy of 6 months of treatment with tacrolimus followed by a single dose of rituximab, and compared this with corticosteroids and cyclophosphamide, and the cyclical therapy was superior to the sequential treatment. In hybrid therapies, combinations of rituximab, cyclophosphamide, and steroids, immunological and clinical remission rates of 100% and 93% respectively reported in 60 patients with treatment-naive, relapsing, and resistant membranous nephropathy. A recently controlled trial looked at combination of cyclosporin, MMF, and prednisolone to cyclical steroids and cyclophosphamide and comparable remission rates. The anti-PLA2R targeted therapy using cyclophosphamide and steroids with treatment withdrawal upon negative anti-PLA2R at 8 weeks showed high initial immunological and clinical remission rates, 71 and 76% respectively, potentially limiting drug exposure. When you have membranous nephropathy with kidney dysfunction, there's limited data on optimal management, but one UK study suggested chlorambucil with steroids was more effective than cyclosporin or supportive care in patients with deteriorating kidney function. And retrospective studies suggest a potential role for rituximab in patients with stage 4 or 5 CKD, showing proteinuria reduction and improved GFR in some patients. Resistant nephropathy would be defined with anti-PLA2R testing, persistence of antibodies at 3 months, and end of therapy may indicate resistance or relapse. And 20 to 40% of patients treated with first-line therapies develop resistance. Management often involves switching between first-line agents, cyclophosphamide, steroids, and rituximab, and CNIs have limited utility in resistant cases. KDIGO suggests rituximab resistance then use rituximab plus CNIs with preserved GFR, or cyclical steroids and cyclophosphamide for declining GFR. If you have cyclophosphamide and steroid resistance, use rituximab. If you have CNI resistance, use rituximab for preserved GFR, or steroid and cyclophosphamide for declining GFR. Other options are hybrid therapies, obinutuzumab and ofatumumab, which has shown promise in resistant cases, including those with anti-rituximab antibodies. Other drugs like ACTH, MMF, bortezomib, dexamethasone, and daratumumab are under a study as well. So in IgA nephropathy, we know of the Oxford-Messi classification, and I encourage everyone to be familiar with that, and most of you would be in their audience. But also but one should be now using the International IgA Nephropathy Risk Prediction tool pretty regularly, which includes CKD, EPI, eGFR, proteinuria over 24 hours, the MAP closest value within 6 months, age for 18 plus only, the race, white, Chinese, or Japanese, or other, the use of RAS inhibitors prior to biopsy, immunosuppression use prior to biopsy, but the MES score here is used without the C score. And risk prediction is now valid till 5 years after the biopsy, and I think it can be a useful tool to guide our therapy. So again, there's a dual approach to IgA nephropathy treatment, addressing both generic and specific pathways. Treatment aims at both intrarenal responses to nephron loss and IgA nephropathy-specific pathogenic pathways, and whether patients have established CKD diagnosis or not. So the foundational, therapy would include low salt, smoking cessation, weight control, exercise, and then the cornerstone of the foundational therapy is RAS blockade and BP management targeting blood pressure less than 120 by 70, and titrating the proteinuria to less than 300 milligrams a day. A meta-analysis of 11 RCTs showed that proteinuria reduction was associated with a lower risk of doubling of serum creatinine and kidney failure, death independent of hypertension. SGLT2 inhibitors as a DAPA-CKD subgroup demonstrated showed protective effects in IgA nephropathy on eGFR and proteinuria, and the hazard ratio was 0.29, although the confidence intervals were a bit wide. However, subsequent meta-analysis of 13 RCTs have clearly shown that RAS inhibitor, the SGLT2 inhibitor use decreases progression of risk by 40% in the glomerular diseases, and specifically in IgA by around 51%. So you have novel endothelin-1 dysregulation, of course, contributes a lot to glomerular hypertension and fibrosis, and targeting these agents, endothelin-1 through sparsentan, which is dual endothelin antagonist, and angiotensin receptor antagonist, or atrasentan, which is selective angiotensin receptor antagonist, both in the PROTECT trial as well as the ALIGN trial, have shown a decrease and decline in GFR compared with irbesartan in the PROTECT trial, minus 2.7 ml per minute compared with minus 3.8 ml per minute. And in atrasentan, again, it seems like there was a significantly greater reduction in urine PCR at 9 months when added to RAS inhibition. The other drivers of therapy include obviously targeting the inflammatory response and fibrosis. And one of the trials, the testing 1 and 2 trials, most of them actually showed decrease in primary outcome, 40% eGFR decline, kidney failure, death, with prednisone 0.8 milligram per kilogram per day, with higher side effects, but also with good effects with 0.4 mg per kg per day of steroids with prophylactic clotrimazole. And still there was some increased infection risk. MMF as an alternative has been used mainly in Chinese patients with where it preserved renal function, allowed for reduced steroid exposure, and hydroxychloroquine also showed some benefit in Chinese patients, but no additional benefit when added to systemic immunosuppression. The intestinal targeted corticosteroid like budesonide in Neffelgard study showed a 48% greater proteinuria reduction at 1 year versus placebo, and 2-year data also showed significantly lower eGFR loss compared with placebo for an average protection of 5 ml per minute per 1.73 meters squared over a 2-year period. And when you're looking at the APRIL TACI pathway inhibitors like atacicept, significant proteinuria reduction in a phase 2b randomized double-blind placebo-controlled trial. There was a 35% reduction in proteinuria reported for patients receiving 150 or 75 milligrams of atacicept for 36 weeks compared with placebo. And there were some other effects on proteinuria, remission of hematuria as well. Similarly, an APRIL inhibitor, sibeprenlimab, in this phase 2 study, there was mean reductions of 47%, 59%, and 63% in terms of proteinuria with 2 milligrams, 4 milligrams, and 8 milligrams compared with 20% reduction in the placebo group. And there was a slower decline in eGFR as well. When there are other aspects like targeting complement, including iptacopan, in APPLAUSE, where we had a phase 2 and interim phase 3 data, which showed significant proteinuria reduction versus placebo, and an interim pre-specified analysis of the first 250 patients showed in the phase 3 trial, APPLAUSE IgAN, that in addition to optimize supportive care, it significantly reduced proteinuria with supportive care alone, and compared with placebo, and it's now been approved by FDA for IgAN. Cemdisiran, RNA inhibitor targeting C5 phase 2 trials also showed a significant reduction of proteinuria compared with placebo, and revolizumab, which is a humanized monoclonal antibody targeting C5, phase 2 trial showed protein reduction and stable GFR versus decline in placebo group. And after 26 weeks, mean proteinuria was reduced by 30% in the revolizumab group compared to placebo. And the mean eGFR remained stable compared with the 24.5 ml per minute GFR in the placebo group. And the phase 3 trial is ongoing. So this kind of summarizes all the four hits of IgA nephropathy, from the production of galactose-deficient IgA, to the formation of autoantibodies, to the formation of circulating IgG, galactose-deficient IgA1 immune complexes, through the deposition of immune complexes in the kidneys, and all these areas that we've discussed, whether targeting budesonide or SGLT2 inhibitors, MMF or BAFF/APRIL inhibitors, or systemic steroids. So I would say you've come a long way, baby. IgA nephropathy, get a 5-star. Membranous, you're getting there, 4 to 5. And the rest of those who've been acknowledged here, all of you are 5-star to me. And thank you for your attention.